Hi everyone, this is Tim, your lecture instructor for the Paramedic to RN nursing program, and today we're going to be doing a voiceover on infection and allergies. It's pretty straightforward. Most of this you already know or at least heard of. I'll point out a couple pages in the book so you can kind of concentrate on those things, and other than that, it's pretty simple. So, infection. So there are several infectious agents, which it could be bacterial, fungal, viruses, or protozoa. This right here is the circle of infection, and as much as we talk about how easy it is to get infection and for it to spread from one person to another, it's simple, but it's almost pretty hard. So if an infectious agent, so let's just say it's a virus, so someone has the common cold, so that would be a reservoir. Someone actually has the disease, and then in order for them to pass on to somebody else, they have to go through portal exit. So whether it be excretions, secretions, skins, or droplets, so that person who has the cold, sneezes, or you're kissing someone who actually has the disease process, is then transferred into somebody else. But that somebody else actually has to have a portal of entry. So whether it be mucous membranes, GI tract, GU tract, respiratory tract, or having broken skin. And they also have to be susceptible. They either are immunosuppressed, have secondary modalities, or trying to fight off something themselves. So again, it's fairly easy to actually transport infection from one person to another, but in the same sense too, it does have to go from someone who is sick to someone who has the potential to be sick. So I don't want you to believe that, oh, we're healthy, we're not going to get sick. But again, it's just right place, right time. So more on the infection, the host interacted with an organism, then they actually become infected. There are several healthcare associated infections, one of them being UTI. Patient came in without one, and then at some point, whether it be having surgery or whether it be incontinent, we put a Foley in them, and then they end up getting a urinary tract infection because we didn't do the right steps to keep them from getting the infection. There's also PICC line infections. There's also pneumonia. So patients who come in that weren't feeling great and laying in bed for several days will eventually get some sort of pneumonia. These three things, if your patient does contract them while they're in the hospital, and we can't prove that they had it prior to coming in, their hospital stay, or at least the interventions we've done to actually get rid of what we've caused, does not get paid for by the insurance. So the hospital ends up eating the cost. So the biggest thing you can actually do is prevent infection from spreading. So infection is transmitted, you stop the transmission, and you stop the infection. So there's several things we can do. So you can do hand sanitizer. They call it gelling in, gelling out. So every hospital room has a dispenser for you to, get the hand gel, and then as you're leaving the room, you gel out. So, me personally, I do this about maybe two, maybe three times, and then at some point, I actually have to wash my hands because then the gel gets kind of greasy. Do standard precautions, so it's gloves and hand washing. According to this, see chart 71-1 on page 2089. So let's see here. All right, so page 2089, chart 71-1, we have hand hygiene methods. I wanted you to be able to read this because it's pretty common practice, but in the same sense too, you'd be surprised at how many nurses don't gel in and gel out and how many don't actually wash their hands after they come in contact with patients. Um, it's just keeping things from spreading from one person to another. You being a nurse, you have 4 or 5 patients. You walk into a patient's room that has, something that is transmittable on your hands, and you end up going to the other 4 rooms. And next thing you know, you're really giving infection to people who are immune compromised, and next thing you know, you're spreading it around. There's also something called isolation precautions. These are patients who either have C. diff, MRSA, VRE. They're highly contagious in the sense that they have something that is really hard for us to get rid of. So the gloves and gowns is really to protect you and them, and also your other patients, and being able to transfer it from one room to another. I believe. Let's see here. If you actually go to 2091, there's a summary of types of precautions, standard precautions, airborne precautions, droplets, and contact. So go through those, know this pretty well, just because, based on what is ailing your patient is going to determine what sort of precaution that you need to actually take to make sure you don't get it and pass it on to others. And I think that was it for that so far. All right, so for prevention, transmission-based precautions, which we just said the 2091 chart 71-2. We have airborne, which could be TB or varicella. We have droplet, which is influenza and meningitis, and we have contact precautions such as C. diff, MRSA, or VRE. The picture is pretty typical of a nurse wearing the gloves and the gown, and like I said, it's just really protecting you from them and also from you actually sending it on to the other 4 or 5 patients you're caring for. Regardless of what I or you believe, there is a way to actually prevent infection, and a lot of it is vaccinations. They're seeing a rise in certain diseases that were either eradicated or were very on the trend of being eradicated because parents and doctors are starting to not vaccinate patients, especially kids, because they believe that either there is something that's causing autism, or whether they just don't believe in it, or they feel that we're introducing something that they don't necessarily need to be introduced at as far as that age, or maybe they want to be introduced naturally. So vaccinations for measles, mumps, rubella, they have the Tdap, varicella, Hep A, shingles, influenza, and pneumonia. And again, I think that the more we vaccinate, the more we actually protect our kids from actually coming in contact with kids who have not been vaccinated and spreading the disease that way. And some of these diseases actually cause horrible side effects, whether it be sterilization, whether it be blindness, organ damages. There's a lot of things that can happen to our kids from not actually causing or preventing disease by giving vaccinations. So for you as a nurse, you're going to do an assessment for signs and symptoms of a disease. You're going to look at the skin, you're going to listen to the lungs, and you're going to do vitals. You looking at their skin is going to, kind of give you more details as far as, are they having a rash? Are they having a reaction to something? Is there something that you're seeing on their body that's a symptom of the infection that they actually have, such as chickenpox? You're going to listen to the lungs. The reason why is because there are a lot of diseases that have secondary symptoms that will cause, whether it be pneumonia or fluid buildup, things like that and stuff. So, and then the vitals, patients who have low blood pressure and high pulse rates, and for a sustained amount of time, that turns into sepsis. So they've gone from being infected to actually getting a blood infection. And then, like I said, the vitals will tend to tell you that, especially the temperature. Temperature is a sure sign of someone having an infection. A lot of the time you're treating the symptoms. So again, example of chickenpox, you really just have to wait it out until it goes away, but you can treat the symptoms of the itching and doing interventions to kind of at least help the person feel better until they actually get over it. One other page I wanted to point out real quick. Let's see here. On page 2097, chart 71-5, assessing for infectious disease. I thought this was pretty interesting and something that I think you can kind of learn from. So check it out. At least understand it and know it pretty well. Patients with infectious disease, I put on here the equipment. You'd be surprised how many times a aide or the nurse will go from room to room using the same vitals machine and not actually wiping it down, or will come out of a contact isolation room after they have used their own personal stethoscope and then not wiping it down in order to use it on the next one. So we forget that the equipment needs to be disinfected every time we actually use it from patient to patient. There's also patient education. How does the infection spread? How do we prevent it? Keeping things clean and keeping your fingers out of your eyes, nose, and mouth. I think we, as a culture of Americans, tend to believe that we're all pretty clean and we clean, keep houses clean, and we tend to bathe every day and stuff. And that's not necessarily the case with everybody that we come in contact with. So a lot of times you're actually providing education to our patients on how they got it, how to prevent it from going either from them to somebody else, or actually getting over it and getting the disease again, and also teaching them how to be clean and a lot of times messy, dirty homes and stuff tend to breed illnesses and disease. Keeping your fingers out of your eyes, nose, and mouth, that's your portal of entry. So, we got to teach our kids and adults and our patients to keep their fingers, stop rubbing your eyes and keep your fingers on your nose, keep your fingers out your orifices and stuff, and that tends to stop or prevent a little bit more disease. Preventing infection transmission, so coming up with strategies to prevent the spread between family members. So your patient, is in the hospital for a certain amount of time, they get over what is ailing them, then they go home, but then, they go to a home to a house full of infected people or people who are still sick or getting over it, and then they get reinfected. So a lot of it's more education and, and try to prevent things from spreading. So this leads on to allergies, and an inappropriate, often harmful response of the immune system to normally harmless substances. So you don't really know what you're allergic to until you come in contact with it. So when you have patients that have a mile-long allergy list, it's because they've probably been in the hospital long enough that they've been in contact with a lot of these medications and been exposed to a lot of things. An allergy is a hypersensitive reaction to an allergen initiated by an immunological mechanism that is usually mediated by IgE antibodies. So you come in contact with something, your body doesn't like it, it produces the IgE antibodies, sends them out, and tells your body, hey, this is your only defense we have against what is not supposed to be here. An allergen is the substance that causes the allergic response, and atopy refers to an allergic reaction characterized by IgE antibody actions and a genetic predisposition. So, for some patients, genetically they're allergic to certain things, and for other people, they're not really allergic to it until they've actually come in contact with it. So, me personally, I'm allergic to kiwi, and I didn't realize that until I was exposed to it when I was about 5 years old, and it caused severe abdominal cramping and diarrhea, which is more of a side effect as opposed to an allergy. But then I ate it again, and then I ended up having a severe allergic response to it. As I get older, I'm now starting to become more allergic to pineapple, which I absolutely love. And because of that, bananas and latex are probably soon going to be another issue because they tend to have the same proteins in them. And again, it's more of just exposure. And sometimes you can be exposed to it all your life and never have a problem. And sometimes you end up eventually developing some sort of problem over time. Allergic reaction. So the allergen triggers the B cell to make IgE antibody, which is attaches to the mast cell. And when the allergen reappears, it binds to the IgE and triggers that mast cell to release its chemicals. Hopefully by now you know that I'm not a chemical composition cell mediated person. So it's not so much as far as you have to know exactly how this works, but just to understand that when you do come in contact with something and you have some sort of allergic reaction, that your body does what it can to actually prevent some sort of severe reaction to it, and sometimes it works and sometimes it doesn't. And that's when you get the anaphylactic reaction type 1. So at some point your body just cannot keep up and do what it needs to make sure that you don't die, and sometimes that doesn't happen. Management of patients with allergic disorders. So you're going to take a history of manifestations, comprehensive allergy history. So I've told you guys in the past, if you don't ask the right question, you don't get the right answer from your patients. So you have to be very specific. Are you allergic to anything? No. Are you allergic to medications? No. Are you allergic to foods? I mean, you have to actually ask them whether or not they're allergic to everything in specific detail, because all of a sudden they have some sort of reaction, or days later you go to give them medication, they're like, oh wait, I'm allergic to that. Well, why didn't you tell us? And well, I didn't really think about it at the time. So a lot of times you really do have to be very detail oriented when you're assessing your patient and asking for a history. Diagnostic test for allergic disorders. They have a CBC that does the eosinophil count, total serum of IgE. And they also can do a skin test, and you want to know precautions. The reason why I put this here is because when I was little, I did have to have a skin allergy test. And back then what they did is they drew a big, huge grid on your back and basically poked you with about 100 different needles to find out what exactly you're allergic to. A lot of times the reaction is more of either raised skin or some sort of rash. There's a noticeable you can definitely see that there's something wrong if you're allergic to what they have exposed you to. The reason why I say precautions because they don't really know how you're going to react to it until you do. So, if they give you something as far as an allergen and you have some sort of anaphylactic shock, you don't really know that that's going to happen until it does. And they also do screening procedures. So, they no longer really use latex in the hospitals anymore. But, when you're in the hospital, your patient is going to come in contact with a lot of things, and you really want to screen them to make sure that you're not introducing something to them. Here's interdermal testing. You're probably familiar with this when we do the TB skin test. It's subcutaneous, or actually it's transdermal. They place the needle under skin, give you a little bit of bleb, and they wait a couple days until you react to it. And you can do this really with anything. Here's your reaction guide. I had a colleague the other day asked me to read her TB skin test. She had been exposed to TB through a patient a couple months back. Because she was worried, I think she was kind of seeing something that really wasn't there. But we use the same guideline to do the TB test. So if you're what you think is reactive, you kind of go to this little scale and find out if truly you're having some sort of reaction. On a little side note, I usually do not come up positive for this TB skin test, but I am allergic to the actual serum that they use to put the TB into, and for about 24 to 48 hours, I get a very large baseball size rash from where it's actually been done. Within about, I'd probably say at least the 48th hour, maybe the next day, the rash tends to go away. So again, we did some testing and found out that I was allergic to it. Not a big deal, but it's one of those things where at first it's like, oh, you might be allergic to it, but you truly have to be, the reaction has to at least be 10 millimeters. The skin tends to be raised, maybe even a little bit blistered, or some sort of noticeable rash that the skin is reacting to. Medication that you can actually take. So oxygen if respiratory assistance is needed. Again, remember your ABCs, airway, breathing, and circulation. If your patient is truly having an anaphylactic reaction, then their throat will swell, their tongue swells, everything seems to swell, and then you need some sort of oral airway. Epinephrine is used for anaphylactic reactions. You can also use histamines like Benadryl. There's several over-the-counter things that you can use that will also help. When I have come in contact with certain things that I'm allergic to, I tend to kind of not necessarily notice very quickly, but I tend to kind of notice that something's different. I have found that if I take an antihistamine and a H2 inhibitor such as like Zantac or Prilosec, that tends to actually help things too. And then you can do corticosteroids, which is an anti-inflammatory, and that tends to work. Prevention and treatment of anaphylaxis, so screen and prevent, treat respiratory problems, oxygen, intubation, and cardiopulmonary resuscitation if needed. You could do epinephrine, which is 1 in 1,000 subcutaneously. You could do auto-injection system like the EpiPen, may follow with IV epinephrine and IV fluids, just to flush the system out. Allergic rhinitis, which is basically a head cold. It could be due to hay fever, seasonal allergies. It's common respiratory allergy presumed to be mediated by type 1 hypersensitivity. It affects 10 to 25% of the population. Symptoms include sneezing, nasal congestion, clear watery discharge, nasal itching, itching of the throat and soft palate, dry cough, hoarseness, and headache. When I first moved here from Ohio, when I lived in Ohio, I had severe allergies to grass and the trees, and just the fact that it was just a lot of hay fever and stuff. I moved here, and I was probably 3 or 4 years allergy free. And then once I got used to the Arizona desert and the dust, I then started developing the same issues. So a lot of times you can move away from what was causing the allergic reaction, and then eventually you become allergic to something else. But most of the time you take medications, whether it be Zyrtec or Claritin or Benadryl or something that will actually help really truly just treat the symptoms or move, so you're not really exposed to all the pollens and allergens that are causing the problems. May affect the quality of life, producing fatigue, loss of sleep, and poor concentration. And I think that's pretty true. When the allergens are getting pretty bad, I just notice people not tending to feel well. And again, all you really can do is just treat the symptoms. The nursing process, the care of the patient with the allergic rhinitis, basically an assessment. So you'll do a health history, including personal and family history. You'll do allergy assessment. You'll find the subjective data, including symptoms and how the patient feels before symptoms become obvious. You'll note relationship between symptoms and seasonal changes, emotional problems, or stress. I can tell you that when the seasons change, which we don't really have a lot of seasons in Arizona, but when we go from the blistering heat to the 50-degree weather, which we think is freezing to death, I can tell that the seasonal change affects me a little bit. I also tell you that when stress tends to kick up, the allergies seem to be a little more pronounced. Identify nature of the allergens, seasonal changes in symptoms, and medication history. So again, allergies really come down to assessing your patient, finding out what they're allergic to or what triggers the allergic reactions. And again, I think the biggest thing you can remember from this entire PowerPoint is that you don't really know what you're allergic to until you're actually exposed to it. For diagnosis, you can do ineffective breathing pattern related to allergic reaction. You can also do deficient knowledge about allergy and the recommended modifications in lifestyle and self-care practices. It sounds pretty basic, but whatever is causing the allergic reaction, stop coming in contact with it. Ineffective individual coping with chronicity of condition and need for environmental modifications. So again, if your allergies are so horrible that you cannot breathe and live, and what's causing your reaction is where is your surroundings, you might just have to move. Collaborative problems and potential complications. So you can have anaphylaxis, you can have impaired breathing, and non-adherence to therapeutic regimen. You'll find throughout all these chapters and all these PowerPoints and all of nursing school and even what you do for a living now, I think that it really comes down to well, I took this pill and it made me feel better, so I must be better, so I stopped taking it. And you'll find that with pretty much any disease process. I don't think it's not necessarily them not purposely being non-compliant, but I think a lot of it has to do with just the layman not really completely understanding what they're taking, for what reason they're taking it for, and that they might have to be on something long-term. For planning, goals may include restoration of normal breathing pattern, increased knowledge about the causes and control of the allergic symptoms, improved coping with alterations and modifications, and absence of complications. Interventions such as teaching, modify the environment to reduce allergens, reduce exposure to people with upper respiratory infections, take deep breaths and cough frequently, instruction to minimize allergens and use of medications, desensitization procedures. Some patients who are allergic to certain things can be actually slowly introduced to the allergen and eventually they can get desensitized. I've heard of this happening with children who are allergic to eggs, peanuts, and other common things. Again, you're really just once a week introducing something to where they still have a reaction from it, but their body, again, is really trying to maintain homeostasis and try to fix itself, and sometimes it really does work. And that's pretty much about it. So, go through the chapter. I was also flipping through the pages, I think 2099, care of the patient with an infectious disease. I mentioned this in past. I really love the nursing care modules and the diagnosis and the interventions and the rationales. I think for you guys, it's really kind of teaching you as far as what to do, why you're doing it, and what you're expecting the outcome to be. So if you have any questions, bring them to class. Thank you.